In a serious medical emergency, every single second counts. They can literally be the difference between life and death. So today, we're going to break down the exact protocol for when a heart is beating dangerously out of control and show you how medics turn that chaos into a clear, life-saving path. All right, put yourself in their shoes. Imagine you're the first responder. The alarms are blaring, the pressure is mounting. This is the reality. We're going to walk through their decision-making process, step by step, almost as if you're the one making the calls.
So what is this emergency actually called? The medical term is wide complex tachycardia. Yeah, it sounds super complicated, but the way it's handled is guided by an incredibly logical and clear set of rules.
So what's actually happening inside the body here? Well, basically, the heart's electrical system has gone haywire. The lower chambers, the ventricles, are firing off way, way too fast. And when that happens, they can't fill up with blood properly. That means the rest of your body, and especially your brain, isn't getting the oxygen it desperately needs. And that, right there, is why this is so incredibly dangerous.
Now, in the middle of all this chaos, a paramedic or a doctor has to cut through all the noise and focus on one single, critical piece of information. Everything that happens from this point on depends on the answer to this one question. That's it. That is the fundamental fork in the road. Is the patient stable or are they unstable? This one determination dictates the entire course of treatment, from how fast you have to act to the actual tools you're going to use.
So, how can you tell the difference? Well, a stable patient, their heart is still racing, right? But they're still getting enough blood to their vital organs. They're awake, they're alert, their thinking is pretty clear. An unstable patient, on the other hand, is showing signs that their body is starting to fail. They might be struggling to breathe, complaining of chest pain, or they could be dizzy, confused. These are all huge red flags.
And this unstable state, it has a medical name: hemodynamic compromise. It's that critical point where the bad rhythm isn't just an electrical problem anymore. Nope, now it's causing a full-blown plumbing crisis for the entire body. And that means we have to act, and we have to act fast.
All right, so let's follow that first, most urgent path. Your patient is unstable. The clock is ticking, and it's ticking loud. This isn't the time for gentle medication. This is about immediate, decisive action to basically reset the heart. This phrase, it's pulled right from the clinical guidelines, and it just sums up the situation perfectly. The patient's blood pressure is dropping, and their organs are starting to suffer because of it. So what do? We have to intervene electrically.
200, that's the number. That's how many joules of electricity are about to be delivered to the patient's heart. It's a very controlled but very powerful jolt, and it's designed to interrupt that chaotic rhythm and give the heart a chance to reset itself. What's really fascinating here is the process. It's not just some random shock. First, if there's time, the patient is sedated, because this can be a pretty distressing procedure. Second, the shock is synchronized. The machine actually times the jolt perfectly with the patient's own heartbeat, which makes it much safer and way more effective. And third, you immediately reevaluate. Did it work? If not, you do it again.
And look how specific these guidelines are. They're right down to the choice of drug for sedation and exactly how it's given. This isn't guesswork at all. Every single step is part of a finely tuned, evidence-based procedure. And if this electrical reset doesn't work and the heart just stops completely, well, that's cardiac arrest. And at that point, the responder has to switch to an entirely different set of guidelines. It's this constant loop: assess, act, and reassess. Okay, let's hit the rewind button. Let's say we answer that first big question differently. Our patient is stable. Their heart is still going way too fast, but for now, their body is coping. The urgency is still there, for sure, but the pace changes. We have a little more time to assess and maybe use medication.
So picture it. The patient is talking to you, but the machine is screaming that there's a huge problem. What's the next fork in the road for a stable patient? Well, it all comes down to looking even closer at the heart's rhythm.
So the very next decision is all about the pattern. Is it regular and predictable, kind of like a metronome that's stuck on fast forward? Or is it totally irregular and chaotic? This distinction is absolutely crucial because it points to different potential causes and helps determine which medication is the right tool for the job.
Okay, so for a stable patient with one of those regular, predictable, fast rhythms, we turn to pharmacology. We're going to try to use drugs to chemically coax the heart back into a normal rhythm, hopefully avoiding the need for an electrical shock altogether.
And the first-line drug of choice here is something called amiodarone. It's a really powerful antiarrhythmic. And again, the protocol is so precise. It's given as a slow, 10-minute infusion. That slow delivery is critical for the drug to work safely and effectively.
But, medicine is never one size fits all. What if the paramedic, maybe based on the patient's history, suspects there's something else going on? Well, the guideline actually accounts for this kind of nuance.
And this is where a drug called adenosine comes in. It's used if the rhythm looks like WCT, but the patient has a known history of a different condition called SVT, which is a fast rhythm that starts above the lower chambers. Adenosine can actually diagnose and treat SVT. And notice the delivery is completely different, a rapid push. It works in seconds and essentially just hits a big reset button on the heart's electrical system.
Now, what about that other path for the stable patient, the one with the irregular rhythm? Well, here the guideline is much more direct. The complexity and the potential causes of an irregular WVCT make amiodarone the safer, recommended choice. It's just a more straightforward decision.
So there we have it. We've walked through the whole decision tree. Unstable versus stable, regular versus irregular. Each question leads to a clear, specific action. Let's just zoom out for a second and think about what this really all means. And this is the whole point. An emergency is chaos, right? By definition. What a protocol like this does is it's a huge shift in emergency medicine. It's the move from just reacting based on instinct to using a proactive, evidence-based system. It provides an orderly path that takes out the guesswork, it standardizes the care, and ultimately, it gives every single patient the best possible chance of survival. It really makes you think, doesn't it? From aviation checklists for pilots to nuclear safety protocols, this kind of structured, logical decision-making is everywhere in high-stakes fields. It's just a powerful reminder that sometimes the absolute best way to handle an overwhelming crisis is with a simple, logical plan.